critical limb ischemia is decrease in the perfusion that threatens the viability of the limb. It is the overall definition, but when it is sudden decrease in the perfusion that threatens the viability of the limb, then it is called as acute limb ischemia. And it could be done by complete or even partial occlusion of the arterial supply to the limb. And critical limb ischemia is more likely than acute limb ischemia. Chronic critical limb ischemia is more likely than acute limb ischemia to be seen in general practice. But for us as a surgeon, when we encounter this acute limb ischemia, most of the time in post-traumatic patients and injury patients, we come across more of these acute limb ischemia. And these chronic limb ischemia are more come more into our outpatient departments with various of its complications with claudication or the symptoms of chronic limb ischemia as an ulcer or gangrene, etc. The hemodynamic definition of critical limb ischemia is when the ankle brachial pressure index is less than 0.4 and reduced to brachial pressure index. When it is less than 0.7, it is limb ischemia only, but when it is more than less than 0.4, it is critical limb ischemia. And transcutaneous pressure of oxygen can also be is also taken as a hemodynamic definition where it is less than 40 millimeter of mercury. So for the acute limb ischemia, except for these thrombotic embolic phenomenon, traumatic is the most common that we come across. Thrombosis is the commonest one, especially in the chronic critical limb ischemia. But when there is plaque rupture and thrombosis in a chronic setting of a chronic limb ischemia, then they might present as acute limb ischemia too. Embolization with some disease elsewhere, either in the heart or as a major peripheral or central arterial aneurysms. In such instances, there can be embolization of the plaque that has been found in these plaque rupture site or inside the heart when they have atrial fibrillation or some structural heart diseases. In such instances, embolization is the second commonest phenomenon of the acute critical limb ischemia. And of course, trauma is another one. And the clinical features of critical limb ischemia in acute setting is sudden onset of pain, pallor, pulselessness, paresthesia, peristhenic cold, and paralysis. These 6 P's that is the famous 6 P's which the patient will present with. And of all, pain is the most common feature that they present with critical limb ischemia. And color change and paresthesia, coldness are more common with the critical limb ischemia who present with chronic critical limb ischemia. So claudication, skin changes of the chronic ischemia like shiny skin, loss of hair, brittle nails, discolored skin, ulcer and gangrene, these are more common in chronic critical limb ischemia. So, and in history, we can always ask for the features of chronic limb ischemia, whether they have claudication, whether they have previous ulcers, whether they have some pulsating mass in the abdomen, pulsating mass somewhere else in the limbs itself, which can cause the thromboembolic phenomenon or can present with acute limb ischemia. It is less common to have critical limb ischemia in the upper limb as compared to the lower limb, but there are conditions where there is critical limb ischemia in the upper limbs, like cervical compression upon the subclavian artery and the formation of the subclavian artery aneurysm with sour embolus, Raynaud's phenomenon, Raynaud's disease. These are the conditions, common conditions that we come across when we deal with critical upper limb ischemia, whereas in lower limb ischemia, it is either atherosclerotic disease is the most common, then structural anomalies of the artery itself, and there are some conditions like popliteal artery syndrome where it is compressed with the ligament and cause the aneurysm of the popliteal artery, or ischemia due to stenosis per se. And there are further embolic phenomenon, then we can think of atrial fibrillation. Heart is the prominent site for the thromboembolic phenomenon, and recent MI with neural thrombus, aortic peripheral arterial aneurysms are the sites which can again have thrombus, and these can embolize. And chronic atherosclerotic plaque rupture can also cause the thrombosis and thromboembolic phenomenon. So whenever we come across the critically ischemic wave, time is the prime thing that we have to consider, and as far as possible, this should be dealt as early as possible. If the limb ischemia acute, especially if they stand for more than 6 hours, then we are always worried about reperfusion injury and limb loss is there. But if we happen to revascularize, then there is high chances that we can come across reperfusion injury and we might lose the patient itself. So classification of the limb ischemia, it is adapted from the Rutherford, and it is category 1 where there is no immediate threat, but the patient might present with features of chronic limb ischemia like claudication, skin changes, ulcers, etc. 2A, it is marginally threatened, and from 2A onwards, we have to intervene in these patients as early as possible. 2A, they are marginally threatened and salvageable if promptly treated, and they have defined in many different aspects, motor deficit, arterial Doppler and venous Doppler findings. The earliest symptoms that comes when there is acute ischemia is the sensory loss. Motor is the last one to be lost in the pattern. So autonomic system is the first to go off, but we neither patient nor we as a clinician try to assess for the autonomic feature loss of acute ischemia. But the sensory loss, definitely we will have to look, and these are the objective things that we can look for while dealing with the critical ischemia. And 3 are those, type 3 are those who have major tissue loss and permanent nerve damage. These are very detrimental. If we try to reperfuse these limbs, then we might lose the patient because of the reperfusion injury or the systemic sepsis. So differential diagnosis of acute ischemia per se are not much, but sometimes acute DVT with cellulose or dolens, they may present as acute ischemic limbs, but they are quite a rare thing to happen either of these in acute DVT. Spinal cord or peripheral nerve compression sometimes can mimic claudication and acute pain of the ischemia, but can well differentiated by thorough examination of the pulse itself. So there are not much of differential diagnosis of acute critical limb ischemia. So while investigating after thorough history and examination is the prime while dealing with the critical limb ischemia, Doppler is the first line of investigations to confirm the diagnosis that we have made with the clinical judgment. And CT angiography is must while dealing with acute limb ischemia in the setting or in the background of the chronic limb ischemia, or when we suspect some other lesions also. But for all practical purposes, CT angiogram should not be waited, because if we wait for the revascularization for the CT scan, it might take some time before we intervene in such patients. So there are CT angiography is reserved for those who have acute critical limb ischemia in the setting of the chronic limb ischemia or the chronic critical limb ischemia per se. Otherwise else we will lose time by obtaining this angiogram. angiographic procedure. And here in the first picture we can see there is lots of feeling in the superficial femoral artery, which is well visualized and well visualized in the CT angiogram. This CT angiogram will have some advantage even in acute limb ischemia setting, that where we should access to the arterial tree of the lower limb, especially lower limb, where we can access to. For this, we will go from the femoral artery itself. If we happen to do with CT angiogram, but while in Doppler, we might not be definitely told about where exactly the lesion is, and we might choose another arterial access for the embolectomy itself. Here in the second picture, there is occlusion of the artery, and there is stenosis. So this could be stenosis. This red arrow shows the stenosis of the artery where thrombosis can occur. And in such settings, only embolectomy might not help in these patients. So CT angiography even after primary embolectomy is logical, so as to tackle these stenosis. When they have these stenosis on top of the acute limb ischemia, then we might have to go and treat these stenosis too. So ankle to brachial MSS, this we have already talked about while dealing with the hemodynamic data, but when it is more than 1.3, then also it is not reliable, and so it is consistent with the finding of the calcified vessels, which are not compressible with the cuff, pneumatic cuff that we are using while taking ankle and brachial throw indices. So normal is between 1.1 to 1.3, low normal is 0.91 to 1, less than 0.9 is mild disease up to the 0.71, and moderate disease is 0.41 to 0.70, and when it is less than 0.40, it is critical limb ischemia. So management, there are some basic conduct for the management of this critical limb ischemia. Whenever we come across acute limb ischemia, it is a surgical emergency, and we should start with high flow oxygen, adequate IV access, and therapeutic dose of heparin as soon as we rule out any other contraindications for the heparin use in such patients. Preferably a bolus dose followed by the initiation of the infusion dose whenever it is practical. And conservative management, there is much less of scope of this conservative management in acute limb ischemia, but in chronic limb ischemia, when they present with critical claudication and skin changes only, and while going for the investigation and investigating, these patients can be considered for the conservative management for the time being. These are mostly rather for 1 or 2A. 2A, we still prefer to go for surgical management rather than the conservative one, but for type 1, when there is no absolute threat to the limb itself, then we can go for the conservative management with prolonged course of heparin, so that we can make out the actual diagnosis, what the cause of the acute thrombosis is in such patients, and we can deal with the cause itself along with the effect of the embolic or thrombotic occlusion of that artery. And regular assessment with APTT and clinical review is the must, along with sonological or CT angiographical review in such patients. And surgical intervention may be warranted if no significant improvement is seen, and when we or the clinician judge that leaving the lesion might cause acute limb ischemia in the future, would also warrant surgical management in such patients. In the surgical intervention, it is mandatory for most of the patients with 2B and above. Embolectomy is most commonly performed procedure, and local intra-arterial thrombolysis with the catheter is another thing that we can do to save these limbs. And bypass surgery, along with these procedures, are in separate, especially in the chronic critical limb ischemia, when there is thrombotic occlusion or the atherosclerotic occlusion is the same. So the surgical intervention that we can go across is bypass or the in situ embolectomy or thrombolysis. So for irreversible ischemia, we should consider amputations early on so that we would not avoid the reperfusion injury and might cause death of the patients because of the reperfusion injury or the sepsis. So long-term management is again reduction of the cardiovascular mortality. In all these patients, they have a cardiovascular, cerebrovascular risk along with the critical limb ischemia. So that should be done. Most cases should be started on antiplatelet agents for the long term, and cases requiring amputation would require to get thorough investigation for the cause and associated other reasons like coronary artery disease, cerebrovascular disease. These things should be considered and looked for in these patients. So complications of acute limb ischemia that we have already come across when dealing with reperfusion injury is the sudden increase in capillary permeability after reperfusion of the ischemic limb and release of the potassium ion, hydrogen ion, myoglobin and other toxins. They cause acute kidney injury and might cost the life of the patient. And hemofiltration with dialysis is the treatment in case of this reperfusion injury, apart from giving bicarbonate, adequate hydration, and diuresis are issued early on when we suspect that the patient has long ischemic period in such instances, so as to prepare for postpone these adverse effects of the reperfusion injury. So the take-home message in this presentation is minutes means muscle, so time is always the prime. Heparinization is thing that we can do as early as possible. Interventional management is must in most of the patients. Amputation and mortality is still high even after we go with this surgical management. And reperfusion injury should be suspicion should be there when we deal with reperfusing critical limbs who have been ischemic for quite a long time. And early suspicion is a key to save lives. Thank you.